Hello everyone. It's time for our final session of the day, Hormone Havoc, What's Going On? Perimenopause, Menopause, HRT and other treatment options explored. Our chair for this session is Katie Taylor, CEO and founder of the Latte Lounge, which is an online platform for women over 40. She will be joined by Diane Dansbrink, psychotherapist, menopause expert and wellbeing consultant, and Dr. Zoe Hodson, lead clinician, Newton Health Menopause and Wellbeing Centre. They will be exploring how to notice perimenopause and menopause symptoms, recognising how they're affecting you and the impact they can have on partners, family life, and most importantly, how and where and why to go for help. They will also share menopause treatment options, bust the myths, explain the risks and share the benefits of the HRT route, and also explore other treatment options, all to empower and take control of your midlife health and well-being. Experiencing many perimenopause symptoms myself, I am really looking forward to this session. So I'll hand you over to Katie to start.
Hi, I hope you can all hear me. Can you hear me, Diane?
Yes, I can hear you perfectly.
Zoe, hi.
Yes. Hi.
Hi, thanks so much for having us here. I'm Katie Taylor. As you can see, I'm the founder and CEO of the Latte Lounge. And you might wonder what that is. So before I tell you a little bit about what the Latte Lounge is, I wanted to tell you all about my own personal experience and why I started what I do and how I came across Diane and Zoe. And then I'll hand over, so you'll hear from Diane and Zoe afterwards in much more detail from a sort of psychological and a medical point of view. So I'm 51 years old now. When I was about 43, I'm a mum of 4 kids. I was very busy. I had a part-time job working for a mental health charity, and I was very busy with my kids, and I used to manage very well. In fact, people used to say, I don't know how you do it, because I just took everything in my stride. But over a period of 4 years, from the age of 43 to 47, I started experiencing a lot of kind of strange symptoms. At first, I didn't think much of them. They were things like extreme tiredness. I put that down to just sort of having a very busy house and working and juggling, you know, everything together. And then, you know, my friends used to joke that I'd always sort of forget things. So I'd say, oh, you know, what's her name? And they'd say, oh God, you're so forgetful. And again, I kind of brushed it aside, just sort of made a joke about it. I was a bit embarrassed, and I used to actually write every appointment down. So, you know, I was the last person to move over to a phone diary. So I used to have a filofax, and I just write everything down so I wouldn't forget. But slowly over the years, I started crying a lot. I didn't cope well at work. I used to just, for no reason at all, feel very teary in meetings, and I'd forget things, and I didn't feel I was doing my job properly. I then became very anxious as well, and sort of lost a lot of self-confidence. So I trotted off to the doctor, and on my first and second visit, I went to 2 different doctors, and each time they said, look, you're a busy mum, you know, I think you just need to perhaps work less, get some more support at home if that's possible. So I carried on like this, and after a while, I was dragging my feet. I mean, I literally couldn't put some fish fingers in the oven for the kids. Everything was an effort. And the anxiety sort of then changed, and I began to get sort of heart palpitations. So I went back to the doctor, and he actually recommended I go and see a psychiatrist. He thought I was suffering from depression, and that I was having panic attacks, and I was becoming very irrational because I was crying a lot. And I fought it because I said, I don't feel depressed. I've got a fantastic life. You know, I don't have any problems. But I trotted off to a psychiatrist who took a lot of notes and prescribed me antidepressants, which I didn't want to take, but I thought I'll try anything because I wasn't living. I just literally, my life was sort of, it was like, the only way I can describe how I felt was walking in a fog. You know, I had this brain fog, and it was like I was living my life, but I wasn't aware of what was going on around me. So I'd go to the theatre, or I'd go to the cinema, or a friend would sort of say something funny, and I didn't find it funny, but I knew I should laugh. Anyway, I back and forward to the doctors. Eventually I was then sent to see a heart specialist, who did lots of heart scans and said, there's nothing wrong with you, and, you know, carry on with the antidepressants and give up your job. So I went home, and eventually I talked to my husband, and I just decided I'm going to have to give up work because I'm not coping. And this went on for 4 years. I gained about 4 stone in weight. I was comfort eating. I didn't exercise anymore because I was just so low. I had low libido. I'm just trying to think what else I had. I had very dry skin. And one day I went round to my father's house, who is a breast cancer professor. He's retired now. And I burst out crying, and I said, Dad, I think I'm going mad because I have this great life and I don't know why I'm depressed, and nothing was helping. And Dad said, I've sort of had enough of you, like, you know, being like this. And I actually think this is hormonal. And I said, but, you know, I'm not having hot flushes. I'm 47 now. I have periods. So how can it be hormones? And he said, go and see a gynae. So I went to see a fabulous gynae, and she took a list of my symptoms, and within half an hour she said, this is classic perimenopause. And this was a word I had never heard of. But when she explained what was going on, it was like a light bulb moment, and I just could not believe that there was a reason for everything I was going through. So we decided to start me on HRT, and I came home that night, and I cried and cried and cried on my bed. I think half out of relief that I wasn't going mad, and half because I had a supposed answer to what was wrong with me, and it wasn't that I needed to be locked up in an asylum. So I turned to Facebook. And on Facebook, I was following a lot of sort of groups from young mums talking about, you know, buggies and nappy rash and play dates. But there was nothing to talk about midlife issues and health problems and, you know, being slightly older. So I set up the Latte Lounge on Facebook. And you might wonder why I called it the Latte Lounge. And that's because I have my best conversations with my best girlfriends in a coffee shop, and we always sort out each other's problems. And I didn't expect many people to join, but that night I had about 2,000 new members, and I was just approving members and members and members, and I realized, A, I was not alone, and more than that, there needed to be a platform for this sort of thing. So the Facebook group carried on, and after about 2 years, I just thought, this is crazy. People are giving some really bad advice or wrong advice, or I'm telling them what to do, but then they're not going anywhere, or they've lost that information. So I decided I was going to sort of build a website and bring on board some contributors. And this is where Diane comes in. I met Diane on my Facebook group, and Diane had also started, and she'll tell you, her own Facebook group called the Menopause Support Network. And I basically said to Diane, look, everyone wants to talk about everything, and there's just so many women just talking non-stop about menopause. Maybe you can come on as a contributor and write and support people and signpost them to where they should be going, because I'm not a doctor, I'm not qualified. And also, if my members only want to talk about menopause and nothing else about midlife health or well-being or fashion or fitness, you know, they can go to Diane's group. Anyway, to cut a long story short, we linked our groups together, and Diane has been absolutely fantastic writing and helping, and I've loved meeting her and working together on all sorts of marvelous things, which she'll tell you about. And then I also met Dr. Louise Newson at another event. And Louise runs Newson Health up in Stratford-upon-Avon. And the lovely Zoe also works for Newson Health. And Zoe will tell you more about what she does in a minute as well. But Dr. Newson has also been very helpful writing and supporting women. So that's my story, and you're all very welcome to join both my Facebook group and Diane's Facebook group and have a look around the website. But really that's enough about me, but that's my background, and I wanted to hand over to introduce you to Diane, who, as Sam has said, is a psychotherapist. She's a menopause expert and she's a passionate campaigner. She's a professional nurse training in menopause. And over to you, Diane.
Thank you, Katie. Hi, everybody. So I'm going to keep this brief because I know that we are, we're sort of limited on time. So as Katie said, my name's Diane Danzebrink. Sort of how I really come to be sitting here is really born out of my own experience of menopause. So in 2012, I had to have a total hysterectomy, including the removal of both of my ovaries. Unfortunately, I didn't have the right advice and support either prior to or post surgery. And this is a very long story short, but essentially that affected me, not so much physically, but psychologically, and took me to a very dark place, essentially to the point of almost taking my own life. And once I didn't find the right help and support, I was guided towards it because I was in no position to help myself. But once I had found the right advice and support, I started to wonder if it was just me that had been so badly affected, if it was just me that felt that she was going mad, that felt like she was no longer herself, that felt like a husk of the woman that she used to be. So I started to research, and obviously back in 2012, 2013, it was more chat rooms than it was things like Facebook groups or Instagram. But I found literally thousands of women saying things like, I feel so alone, I feel like I'm going mad, I don't feel like me anymore, I think I'm going to have to give up my job, my relationship's falling apart. And I thought, okay, this can't be right. We're 51% of the population, somebody's got to do something about this. And I'll be really honest, at the time I was in no position to do anything about it. I had to focus on getting me well first. But a couple of years later, as Katie said, I'm a therapist. I have professional nurse training in menopause. So I combined the two, and I started to focus my work specifically on supporting women going through menopause, talking to them, just really kind of creating a space where they could talk about their symptoms, what they could do about it, if they were struggling with getting past their healthcare professional, but then also, more importantly, more holistically, about how that was affecting the rest of their life, whether it was their work or their relationships, etc., etc. I then decided that it was important to do something a bit wider than that. So I set up, as Katie said, the Menopause Support Network on Facebook. I created a website called menopausesupport.co.uk. And then in October 2018, I had just spoken to one too many women who had been failed. And I sat one night at my computer and, without any conversation with anybody, decided to launch a national campaign called the Make Menopause Matter campaign. The campaign has three clear aims. The first one is to have mandatory education for all our GPs. The second, menopause education, that is. The second one is to have menopause guidance in every workplace. And the third one was to have menopause included in the new RSE curriculum in secondary education. I'm delighted to say that within a year of launching the campaign, we achieved education in England, and now menopause will be included in the new RSE curriculum from September this year. So that sort of pretty much brings you up to date. I think we've got about 120,000 signatures now on the campaign, and I would love you all very much if you would consider going and having a look at it. So you can find the link on menopausesupport.co.uk. But essentially, probably like Zoe, I sort of eat, sleep, drink, breathe menopause. There's a lot of us who are very passionate about making change. We lobby MPs, we speak out as often as possible, because I think we've just decided that we have to be the generation to make a change for the future. So that's me, and now over to my lovely friend and colleague, Zoe.
Hello, so lovely to meet everybody. So I first started because I was GP in South Manchester for over 15 years now, and I was a GP trainer and doing all of the family planning stuff, but I just thought I don't think I'm very good at menopause. So I started to read around this a couple of years ago, and then I dog walk with a nutritional therapist and a yoga teacher. And for about 4 months, we were mulling backwards and forwards saying, wouldn't it be wonderful if we had a centre for women that could cater for the menopausal change and we could encompass all of these things. And then, as you'll see, my crochet boxes behind me, I'm a little bit of a crochet nerd. And one of my lovely crochet friends said, have you heard of Louise Newson? And I thought, well, I saw her write in Pulse years ago. She covered medical articles. And then she said, no, she's got a centre down in Stratford. And it was everything that we'd been talking about. So I trotted down there for a day and we just hit it off. And then she said, I would love to open something in Manchester. And that was a year ago. So the year has just been incredible. It's been, my partner now has to say, he says he's changed his mind. He said, I'll only listen to him if he puts the word estrogen or testosterone in a sentence. So he slides that into every conversation. So we've set up the centre, and then Louise's centre is very established. We've just started with the Manchester one. So unfortunately, there are a lot of politics involved in menopause care, and I won't go into too many of them, but it is nigh on impossible to run an NHS menopause clinic. I tried to do it in general practice and tried several different avenues and was told there isn't the funding. I tried to introduce it with the training and was told it's already on the curriculum. We don't need separate time for this. And this is in a 10-year training program that there's deemed there isn't time to have a specific, I asked for an afternoon. I asked for an hour at the end of a day. And they said, no, it's already on the curriculum. We don't need it. So this is what we're facing. Yeah. And I think, as Diane, we're really keen. I think we realise that it's such a huge issue, and that I think the social media is just so powerful with this. It's not everyone's favourite thing, but I think the connection with women is just incredible. And Diane's work and Katie's work, there's a real energy about this now. And I think what we want for the next generation, well, there are many things we want for the next generation, but I think what's happening at the moment is women are no longer feeling alone with this. There are so many groups where they can come, because it can be the most isolating thing. And we'll just talk, if I just talk you through a typical woman that I would see in the clinic. And we are starting to see, and it just brings me so much joy, we're starting to see younger women who have recognized their symptoms. And so we have different groups of women. We'll have some women who, I had one lady, there are a lot of tears in menopause work, lots and lots of tears. So I had a lady the other day who just said, I feel like I've lost 10 years of my life. And the very, very common story, Katie will have heard it, Diane will have heard it, they'd been backwards and forwards to specialists and they'd had blood tests repeated and repeated and repeated. And this one lady, she'd been on these incredible cruise holidays and she said, I felt nothing. And she said, I've got 4 beautiful grandchildren and I feel nothing. And the guilt of that, and she said, this has been for 10 years and you're now telling me that I could have had some help with this. And it's absolutely heartbreaking, and we hear it every single day. And I do include the weekends because all of us will try and do a lot of work behind the scenes on social media, and we have women messaging us, and we're all trying to help as many people as we can. So if I'll talk through one of the younger women that has come to the clinic. And so this was a lady who was 44,
And some of the younger women, they'll come and they've obviously read through a lot of information on the Menopause Doctor website, and there are podcasts on there. And she sat there, and then she suddenly had this rabbit in the headlights and said, am I in the right place? And there was this thing of, I've been told by so many people and so many healthcare professionals that this can't be menopause. And I've been told by work that I just need to drop my hours. And I think there was a sudden panic that this wasn't the right place. And we give out a symptom checker. And I said, but look at your symptom checker. You filled it in. She'd scored something like 50. And I think when you start to also, I'll go through a few of the common symptoms that women will experience early on in the journey. And a bit like Katie said, you very often can get things like palpitations. You can get horrible anxiety. And it's a real sort of bolts of adrenaline. Lots of women are unable to travel by the tram, by car. They can't go in lifts. So you get this sort of claustrophobia where you can't go into confined spaces. You can get something called the rage, which can be quite potent. And so you start to isolate from your friends and your family because you don't know what mood you're going to be in. You have no idea what's happening to you. You have estrogen receptors everywhere. So it can be your hair can change, your skin can change, your joints can become uncomfortable. You can get this awful walking through treacle sort of lethargy, brain fog, word finding problems. We see lots of women that started there, and I'll call it a journey because it is a journey, with bladder symptoms. And that was my journey. And a friend of mine had very common again. She realised she'd had several £1,000s spent. She'd had urine infections. She'd been for cystoscopies. She'd then developed tinnitus, and then she'd had a bit of anxiety. And I can see as a GP, if you didn't have these things called a symptom checker, and Diane's got one on the Menopause Support, there's one on Louise Newson's site on the Menopause Doctor, and then there's a new app called Balance, which is free. I'll show you a little. I'll have to do this, otherwise Louise will shoot me. So that's the free app, and that has a lot of information. And it's only when you sit down with a woman and say, do you tick these symptoms? And many women, because many women are misdiagnosed with things like fibromyalgia, and they just, lots of them will say, I just feel, I don't know who I am. I feel like I'm a shadow. And as Katie said, I just feel that I'm not living anymore. I'm not me. I don't know who I am. So when we see women in the consultation, it's first of all, yes, you are in the right place. You know that there's something different. This is not in your head. You feel different. And yes, these symptoms can fluctuate because hormones fluctuate. And we would all really love to just get rid of the word menopause for a starting point. We'd love to start to look at it as a female hormone deficiency. Because if you do that, you start to look at it more rationally, because your hormones fluctuate, and this can happen at any age. And it's looking at the patterns of fluctuation. So the younger women that are coming into the clinic, we need to move the timescale. So the average age of menopause is 51. But we know that 1 in 100 women will be menopausal below the age of 40, and 1 in 1,000 below the age of 30. And of course, there's a sort of a bell-shaped curve. And then to add into that, you can experience perimenopausal symptoms for 10 years before menopause. And this is when it suddenly all starts to make sense. And often women will have clusters of symptoms and then they will go. So by the time they book the GP appointment, they feel fine, and they feel a bit of a fraud for taking up a busy GP appointment. And then they come back again and things have changed. So things like the hot flushes are not the things that generally bring women to come and see us. It's the psychological symptoms. It's the anxiety, it's the low mood, it's the irritability, it's the brain fog, it's the just not being able to concentrate, it's the lethargy. So thank you, Katie. Someone's just
fine. I was just going to interrupt you for 30 seconds. Or you're in a fantastic flow. Because what I wanted to ask is really, you're talking about the younger woman or the older woman coming in to see you. But if we get, you know, just going to Diane for just 30 seconds, and I want to come back to you. If you're feeling, a lot of women are writing that they relate to what we're talking about and they're relating to these symptoms. Just quickly to Diane, what would their first port of call be? Well, what should they do almost before they go to see someone like Zoe and Louise?
Well,
in an ideal world.
Women, here we go. In an ideal world,
yes.
For most women, their first port of call, so I think the thing is, I think it's important to say, Katie, that approximately 1 in 4 women will have no symptoms of menopause. 3 out of 4 will, and 1 in 4 will experience what we would call debilitating symptoms. So you described your symptoms, so severely affecting your quality of life. So 1 in 4 might never consider going and doing anything, and Zoe will talk about why that's important as far as long-term health is concerned. But 3 out of 4 might consider going and seeing their GP. Now, the difficulty there is that with GPs, essentially in their education is very little, if anything at all, about menopause. So I have been campaigning the Royal College of GPs for many years, and as you know, Katie, you co-signed a letter with me recently, which we got a totally nonsense reply to yet again, telling us that it's, as Zoe said earlier, it's already on the curriculum. You know, these GP trainees have to be assessed to understand menopause to pass their exam. Well, I'm sorry for any GPs that are listening, but if that's true, then the exams need looking at again. Because what Zoe's talking about in the clinic is that they're seeing all the women, or no, that's not fair. A proportion of women will always choose to go privately, but what they're seeing is they're seeing an awful lot of women who can't get the right help and support from their GP. So it's fair to say that there are a small number of GPs who will have done some kind of continued professional development, whether that's through the British Menopause Society, Faculty of Sexual Health, Royal College of Obs and Gynae, etc. They may have done. There may be a practice nurse. So my training was done with practice nurses, with gynae nurses, etc., etc. So there may be a practice nurse who's done some menopause training, but unfortunately, because it isn't a mandatory part of the curriculum, essentially, we're not equipping GPs with the right education to be able to help potentially 51% of the population. So very often what happens is women will go along to the doctors, and if their symptoms aren't classic hot flushes and periods changing, if they're things like anxiety, low mood, mood swings, irritability, cognitive symptoms like memory, concentration, brain fog, etc., etc., quite often they'll be told, well, you're depressed, like you were, you need antidepressants, and they'll essentially be shooed away. Off you go, you're depressed, you need. And if the woman then develops joint pain or urinary and vaginal symptoms that she might not even recognize are related to menopause, she might go back 6, 7, 8 times with separate issues, which, you know, in a 10-minute appointment, how many things can you deal with? So she might take up an awful lot of GP appointments. She might waste an awful lot of time trying to get to the bottom of why she's experiencing all these things. And if we only gave, and you know, Zoe said earlier, she'd asked for an afternoon, she'd asked for an hour to teach. Genuinely, you could give enough information in a 1-hour session to upskill GPs and practice nurses. You know, it's not brain surgery. And I think, sorry, go on.
No, what I was going to say is rewinding and what you both said before. And for all of you who are watching, if you go and get the symptom checklist on Diane's website, or it's on my website, or it's on Nhs Health, or even better on the Balance app, if you take those symptom checklist to your nurse or to your GP or your menopause specialist, at least that cuts down on time, and then the conversation gets going.
Well, I think as a GP, that symptom checker, I had never come across it before until a few years ago. That that in itself was absolutely practice changing.
Yeah.
Even taking that into your GP or your practice nurse, you start to, it's like this, it's almost opens the menopause window and you start to see it everywhere.
Yeah. And I think the other thing, Zoe, that we must say is there's been so much scaremongering, because even for me, and my dad's a breast cancer professor, and even I was scared off when she said the word HRT, because I've read headlines and, you know, a lot of people who thought they were being helpful saying, oh, it causes breast cancer. And so can you just talk to people a little bit, because a lot of people want to take HRT and I know how beneficial it is, but can you talk about why that happened, why women were scared off, and the headlines behind it, and why we should feel reassured, and obviously why it's helpful?
Well, this actually has all happened since I've been a GP. So when I was a GP trainee, loads and loads of women were on HRT and I just didn't question it at all. And at that training practice, because I became a partner there, then the WHI trial came out, and I think most women will probably have heard about this. And there are so many flaws. I haven't got time to go into them all here, but one of the major ones, it was actually, the study was a huge, expensive study, but it was to look at cardiovascular disease. It was not to look at breast cancer data. So a real fundamental point of this, you have a group and then you have a control group. And the control group were, so what you try and do in these studies is age and weight and all these characteristics, you match sort of placebo and the treatment arm. And they were matched for cardiovascular disease, they were not matched for breast cancer risk. And so the data, there were, as I say, I can't even go into how many flaws there were with this. The data, normally with a massive study like that, all of the people involved in the trial should sign the trial off. They should have seen the results, agreed on it and signed it before it goes to press. It got sent to the press before the scientists had seen it, and literally overnight, and as a GP trainee, I think you're still, having done my hospital training, which was very much learn by humiliation, you don't question anything. Well, then it was suddenly, right, well, we just have to take everyone off HRT. And the most ridiculous thing is it took years, and I'm talking 18 years, and we're only just digging into that and saying, really, is this what the study showed? And so a lot of the things it was using, and I think that's your reservations about HRT, Diane, was you didn't want to go on the horse urine stuff. And so in those days, they were using relatively high doses of synthetic hormones, and you have to, you tailor the hormones. And as I say, it was just a one size fits all. And what they found was that there were a lot more reports of women with breast cancer, but it wasn't explored fully. And what we know now, because I think, I mean, your father's done a wonderful podcast with, there's Earl, and there's a chap, I'll just get the book quickly, if anyone wants to really read into this, there's a, I know it's back to front, but there's a fabulous book called Estrogen Matters.
Yeah, it's by Dr. Avram Blooming. It's actually Dad helped edit it. It's fantastic.
Yeah. So when you, and we will cover this during appointments, when you look at breast cancer, there is a tiny link that potentially with HRT and breast cancer. And there's been a Cancer Research UK, and it showed that 2% of breast cancers could potentially be linked to HRT, 30% to lifestyle. So what we know, that breast cancer is a common cancer, but we know there is no proven association with breast cancer deaths and HRT. We know that younger women on HRT, there's no increased risk. We know that women who've had a hysterectomy and are on estrogen, there are no increased risks. And what we look at is actually the progestogen and not the estrogen that is linked to the breast cancer. And again, I don't think I've got it to hand, but there's a really good risk chart. And we know that actually having a glass of wine or two of alcohol per night has a higher risk of breast cancer than HRT. We know that carrying weight, being overweight, will double your baseline risk of HRT. And we know that not exercising. So this is where, as I say, the 2% possibly linked to HRT and the 30% to lifestyle. And what we look at is many women that come to the clinic are often using alcohol because their sleep is terrible. So many women have increased their alcohol. They're trying to settle their anxiety. We know that many women will start to gain weight because what happens is when your ovarian estrogen is dropping down, your body will try to get a different form of estrogen from fat cells. So you start to get this sort of classic spare tire, and you start to crave carbohydrates because it's linked to something called your glycemic index and your cortisol. All the pathways go backwards and forwards. So I had a lovely lady the other day who said, I've been driving around craving jelly tots. She said, I don't even like jelly tots, and I'm here in the car at 10 o'clock at night because I just need carbs. And then we know that people will have joint pains. Lots of women who've had running as a sort of a stress relief and say, I can't because I don't have the energy. So when you look at it, often when women go on to, and we look at this at the 3-month review, and I always say if women are going on to HRT, well then have a look, see what factors you've got in your life, so things like smoking, alcohol and exercise. What are the things that if you were feeling better that you could start to address and reduce your risk? And I think you have to look at it holistically. We know that even things that Dan was saying earlier, we're looking at disease prevention. So we know that 1 in 2 women over the age of 50 will have some sort of fracture. We know that osteoporosis is a bit of a silent thing. We get women with sort of vertebral fractures, and it's 1 in 5 men. We know that there's an increased risk of diabetes. We know that there's an increased risk of heart disease without estrogen. And you have to start looking at the big picture as well, of course, as the health, well-being, able to function, able to enjoy life, able to work. So I think this is, again, it's all been due to this awful study and then the sort of clickbait headlines, which came out again in August last year. It resurfaced. And you just think, oh, for goodness sake, can we just try and put some rationale behind this?
And that's why I really recommend that when you're on social media or listening to your well-meaning friends, just keep going back to whether it's the Nhs Health app or to Diane's website or my website, just evidence-based, science, follow all the blogs or the books that we both will recommend and any podcasts. For women that perhaps can't take HRT or don't want to, what other options are there other than the sort of classic sort of healthy lifestyle? Because we get a lot of women saying, oh, try this herb, try this crystal. And I sort of jump on it because I'm very wary of anything that says the word homeopathy next to it. So what else could women try if they didn't want to go down the HRT route?
I think it is sort of checking in and looking at, right, we need to have a check-in now on my long-term bone health and my long-term heart health, and how can I best maintain those? So the nutrition side of things, I think is going to come into its own. It's another really undervalued area in conventional medicine. So there's a neuroscientist called Lisa Mosconi who's done a book on brain food and looking at that. So I think changing your nutrition can have a huge beneficial effect, because we know that a lot of the symptoms are linked to, you can get this rise in cortisol, you can get this insulin resistance, and it's looking at really sort of chipping away at these and doing as much as you can, because those can reduce inflammation, they can reduce fatigue, they can help with your sleep. So I would probably recommend seeing a really good nutritional therapist that understands hormonal pathways, rather than, honestly, if I collected the bags of supplements that women are on, and I just think you'd be better. There are lots of nutritional therapists online, and I think reading through and really understanding why you're taking that supplement. Mm-hmm. Because a lovely friend of mine has been sort of shoveling flax seeds in by the bucket full, and doing all of these other things. And finally she sort of said, well, I'm trying to increase my estrogen doing this, and it's really taking up a lot of time. Maybe I'd be better just getting some estrogen. So I think with something like that, and I think there's other things, again, there seems to be a real backlash with conventional medicine against lifestyle medicine. And I don't know what's driving this. There seems to be a real fear of change in conventional medicine. It's seen as a threat. And to me, it just makes so much sense. I think if I hadn't done this, I would have done functional medicine. So it's looking at what's causing the inflammation. What can we do to, so for example, it's looking at yoga has a massive effect, beneficial effect, because it's a transition time and it feels really unsettling. So if you can find something that grounds and calms down that sympathetic nervous system. And this is why things like acupuncture can help, and all of the complementary therapies. And some of them don't have much evidence base, but women report that they're helpful.
Yeah.
So I think, well, look at the studies that have been done on a lot of conventional medicine. They weren't even done on women. So it's time really, I think, for us to start our own sort of textbooks with this.
And I think it's funny because it's a bit of a chicken and egg scenario, because as you have alluded to, when I felt terrible, I started eating rubbish because it was comforting, because no one else was giving me the comfort that I needed. And then the more rubbish I ate, the less exercise I did, and then the less self-confidence I had. And I have to say, and Diane, I had a hysterectomy, Diane has had a hysterectomy as well. Now I had a hysterectomy.
Feeling left out.
After a while. I had adenomyosis, which I didn't know I had, and there was a lot of heavy bleeding. And originally I was advised to have a coil to A, stop the bleeding, and B, give me the progesterone, and then to have the estrogen patches. For whatever reason, the coil, they couldn't fit it for me because I'd had a lot of scar tissue through cesarean sections. But once I had the hysterectomy, which I was very frightened about having, I was told I only needed to have estrogen only. Once the heavy bleeding stopped, I was no longer tired because I became seriously anemic. So now that I've kind of come full circle, I'm only on estrogen, I don't have the bleeding, I feel amazing. For the first time in 7 years, I've finally been in the headspace to eat well. You know, I've lost 2.5 stone this year, which I've not been able to do in 10 years. I feel like exercising. And so ironically, I feel better now than I did in my 20s. And that's what I want for all these women, is to get out of this horrible cycle, which is, you know, and I, like everyone else, there's a lot of people talking about, you know, evening primrose and black cohosh. I tried everything. I tried diet, I tried exercise, I tried supplements. And Diane is nodding. I'm sure you well, you know, you hear this all the time.
I think the thing is, Katie, is, you know, sort of this decision about how you manage your menopause has to be informed choice. And whatever choice a woman makes, that shouldn't be, you know, that shouldn't be up for criticism. However, it's about having factual, evidence-based, non-biased information. And unfortunately, menopause is now a big market. Menopause is a massive marketing opportunity. So, you know, we really need to think about how do we ensure that every woman has access to factual, evidence-based information, because, you know, with the best will in the world, whatever you're taking, only estrogen, estradiol, which is the most potent of the 3 estrogens that we produce, that's the one that we're losing rapidly during that menopausal transition. Only estradiol will replace estradiol. Now, are there very, very weak types of plant estrogen? Yes, there are. But as Zoe said, she had a friend that was shoveling them in by the bucket load to try to deal with her symptoms. Is it a choice whether or not you have it? Yes, of course it's a choice. But it's also important to say that for women like you and me, Katie, who are on estrogen only and don't have to have progesterone because we no longer have our womb. So for those of you that are not aware, the reason that progesterone is given alongside estrogen in HRT is for women with a womb, it's to provide what's called endometrial protection. So that's the lining of your womb. But for women like you and me on estrogen only, there are no increased risks. If you're a woman under 50 on combined HRT, there are no increased risks. For most women under the age of 60, the pros of HRT really massively outweigh the cons. There are a handful of women, a small percentage, who absolutely must be referred into a menopause specialist clinic. And it's important to say that as well as private clinics, there are a few, British Menopause Society led. So they're accredited menopause specialists in the NHS. I think we did a survey recently, there's about 60 around the country. One of the unfortunate things is that most of those clinics only run for half a day or 1 day a week, and most of them have got waiting lists of between 3 and 6 months, but they are there. But if you're somebody who's got a complex history, or your GP feels that they're not able to deal with sort of whatever it is you're presenting at menopause, then it is a possibility. I think the other thing that's really important to mention before we run out of time is the NICE guidelines on menopause. So back in 2015, these were published. It was the very first time that there had ever been any medical guidelines on menopause from NICE. So that's only 5 years ago. There are NICE guidelines on everything. And, I've met a lot of GPs over the last few years, and most of them are stressed to the max. Some of them have given up altogether, others have gone part-time, because there are a huge amount of these that they're supposed to have read. Most GPs have no idea what's in NICE guidelines for menopause, but they're not just for GPs, they're for women too. So as a guideline goes, it's actually not that bad. It's about 30 pages. But if you're going to go along to your GP, print off one of the symptom checkers, have a look at the NICE guidelines, know what they say, know what you should expect. And you can find other things like, so on the menopause support website, you can find something called 10 things your doctor should know about menopause, preparing for an appointment. There's loads of information on the menopause doctor website. Katie, I know there's loads of info on your website too. So there is lots of information out there. It's just knowing where to go for it and feeling prepared. And do you know what? There were times when, and I know this is the same for you, Katie, there were times when just picking up the phone to make an appointment, and I speak to so many women now who say, I just feel like I'm being a nuisance.
Yeah.
I haven't got it in me. My confidence has gone. I don't want to go back and talk to another doctor. And if that's how you're feeling, rope in either a really good friend or a partner or a family member and take them with you. They don't have to speak for you, but just have them there for support, because support can be so important when you're not feeling yourself. Absolutely.
I'm going to just go through some of the questions down the side.
Katie,
yeah.
Katie, can I just very, very quickly, because I think we haven't covered it yet. There's a couple of things popping up. So just common things, reasons that women are told they can't have HRT are to do with clot risk. So women who have migraine, women who've had previous clot, women if they're overweight, and you can have, and lots of GPs don't know this, because when it comes to the contraceptive pill, there's a risk guide, and all of these things say, if you've had migraine, this, that, and the other, you cannot have estrogen in the pill. So there's a misunderstanding that means that you can't have it with HRT. I've just got a couple of them. So we use through the skin HRT. It doesn't go through the clotting pathway, so there's no risk of clot. There's some patches. There's the gel, and then there's a little spray that's come out as well. But just to clarify that, because that causes a lot of confusion as well.
And a lot of people, when they put their patch on, they're not quite sure where to put it. Obviously, it's on the instructions, but is it right? It has to be below the waist.
Below the waist. Yeah.
Yeah. Okay.
Yeah.
So, I mean, a lot of people are sort of saying, there's someone here, Lady Rachel, saying, I'm in Kent/London. I see a counsellor, I could do a singer professional. I mean, on the BMS website, that if you type in your postcode, it will say where your nearest NHS or private specialist is. Obviously, Diane does one-to-one consultations, and so does Zoe, and so does Dr. Newson. I'm just going to see, how do I know the difference? Michelle says, Zoe, it sounds like my PMDD symptoms. How would I know the difference?
I think that's slightly more complex, and you do have to navigate it through. So I think you're looking at a cyclical pattern. You're just looking at the hormone deficiencies, and I have to say, Dr. Hannah Short in Cambridge, I would say, is one of the top PMDD experts. So we tend to, ours is mainly focused on sort of perimenopause, menopause. So she would probably be more of your go-to for that. But you're looking at really just picking apart the hormones. Even we haven't even mentioned my favorite one, testosterone.
Oh yes. Could you quickly, because
okay.
So that was something I didn't know with this whole low libido. It's a very embarrassing, very personal thing. You know, everyone wouldn't dream of talking to anyone. So the first time I vaguely even mentioned it at the doctor, they said, oh, well, you know, there's nothing we can do about it. But then when I started working with Diane and Louise, I heard that testosterone could help. Now, I'm sure everyone will think like I thought, oh, that's just a male bodybuilder hormone, and I don't want to grow a beard and you know, get muscly. So talk to me very quickly, because we haven't got that long, about the function of testosterone. So this was
same thing with my GP. When I told him I was on testosterone. He said, well, of course you feel better, it's a sex steroid hormone. And I said, yes, but A, I'm not bearded, and B, it's replacing a deficiency, and you produce more testosterone than estrogen from the ovaries. And if you thought HRT was difficult, trying getting sort of testosterone onto the NHS radar is a whole other ballgame. But if we can do, because we will do, we're changing things. I think the licensing, presumably, and I'm just going to go into it here, was probably made up by a panel of men, because the main licensing is for sex drive. The thing that interests me about it is it's for brain cognition. So your word finding, your brain fog, your brain sharpness, your energy, your muscle strength. So it just brings back women. It is the most wonderful feeling when it's gone, because it can feel like someone has wadged a big load of cotton wool down the middle. And so again, another friend of mine had to do a presentation, couldn't even remember her own name. It's that horrible feeling like the connections have gone. Now, again, it's a real postcode lottery, and trying to even get it on the Manchester formulary. We're still battling with this. It's different from area to area. And I think it has to come back to Diane's things, that we need the education there, that we need GPs to be familiar with it. So we have got a long way to go. The Nhs Menopause Clinics, you can get it from there. And in most areas, once it's been started by a specialist clinic, it should be able to go back to your GP. Now, I do feel for GPs, because the idea of prescribing something that you've never been taught about is utterly terrifying. So we always say that if we can, I've got a couple of GPs at the moment that there's been a hint that they might prescribe it. So it's that thing of, right, if you want to go near it, talk to me. I'm more than happy to coach you through. But again, you have to get past the red tape. We need the education in there. We need medical students. We need all specialties. We need everyone to be aware of this.
And this is what Diane is campaigning for, and I'm obviously supporting her. I always will. It's so important. And with low libido, I mean, I must say testosterone doesn't work for everyone, but with low libido also comes vaginal dryness, another taboo, very embarrassing thing. And they often, you know, prescribe, is Vagisil and what's the cream, Diane?
So there's Vagifem, which is a pessary, then there's estriol cream, Ovestin cream, then we've got 8 different products now. Can we just quickly, have we got time, Katie, just quickly to talk about repeated UTIs and things?
Yeah, absolutely, because in the press today there was something about it. Okay,
so I think, you know, sort of talking about things that we don't talk about, so libido, but also vaginal atrophy, or vaginal symptoms, urinary symptoms. So many women will experience vaginal symptoms or repeated UTIs, etc., and have no clue that they might be related to menopause. Some people go through their menopause, go into postmenopause, and then they'll develop things like UTIs, vaginal dryness, soreness, irritation, etc., etc. And it's so sad, because so many women just think that they have to put up with it. It's just something that they've got to live with. And of course, if we sort of take that a stage further, the reason that most women are admitted into care as they age is either dementia or double incontinence. And some of those things, not all of them, but some of those things could be addressed if only women got the right help and the right treatment at the right time. So if you take one thing that I say away from this, please don't put up with those urinary and vaginal symptoms. If you're on a merry-go-round of 3 days antibiotics and another UTI, 3 days antibiotics and another UTI, please go back and talk to your doctor again, or talk to a different doctor, or see the practice nurse. Jane Lewis has written a brilliant book called Me and My Menopausal Vagina, and she's also got a website which I think is mymenopausal.vagina.co.uk. And Jane also runs a private Facebook group which is just, it's obviously it's private, but it's just called Vaginal Atrophy, and she's written a lot about it. And as I say, just please don't suffer in silence, because I think so many of us have seen, particularly when we think about our grandmothers, you know, we have seen them suffer when perhaps we didn't know what was going on. So, you know, talk about it and get the right help that you need.
We've got 5 more minutes. So
sorry, just one more quick thing on that. She's done some absolutely incredible, Jane's done some amazing videos recently on chronic UTI and vaginal estrogen on Instagram, and I think, are they all saved on there, Diane?
Yeah, they're all on IGTV. Yeah.
So if you're suffering from either of those, they are just brilliant.
Absolutely. I mean, I'm going to wrap up and answer and go through a couple of questions, but also just, we haven't said that the benefits of HRT, you know, also can prevent osteoporosis and reduce heart disease. So there's a lot of pluses. It's not just about your symptoms, but it's long-term health. Now, someone here has said, I think what we'll have to do as well. That's Dr. Newson's book. Yes, it's a massive topic. We need a lot longer. There's a lot we can talk about.
A few weeks.
We could go on for weeks. Sorry, let me just have a quick look through. Does the Dr. Newson's app give recipes, Zoe? Do you know?
Not at the moment, but I think it will. There are lots of, so there's a lady called Emma Ellis Flint she's on social media, so she
writes for our website as well, actually.
Yeah.
In fact, a lot of the women we've talked about, Jane Lewis and Emma and Diane and Louise, that they also write for our website. So if you want to email me, katie@lattelounge.co, and I can then signpost you off to Zoe, to Diane, to Jane, anyone else, you know, use me as a sort of centre point, and I will just sort of signpost you merrily off on your way. I'm going to have one quick little look for one last one. Okay, very quickly to sum up, Zoe, migraines. Someone said here, so it's Amanda, I couldn't take the pill because of focal migraines. Will I be able to take HRT if needed?
Yes. There's a very good leaflet. If you go onto the Menopause Doctor website, and it's under resources. There's a leaflet all about migraines and HRT, but yes, absolutely fine.
Okay, perfect. Live well. Oh, thank you, Sam. Everything is going to be shared. Have we got 2 more minutes because there's a lot of questions I want to go through.
You ready, Diane?
It's all being recorded, so you will get to be able to watch this, you know, in your own time. And let's just have a quick look.
You can do another few questions if you like. Carry on.
Oh, can I, Sam? Okay,
yeah,
perfect.
There's so many here. Just
I know. Oh, I know, a big one. So someone has said, I've had a blood test for perimenopause and it comes back negative, even though I've experienced symptoms. All, you can see we're all like, we get this all the time. Talk about blood tests, Zoe, and why they're not reliable.
This is, I mean, I had a lady the other day, and she ticked every single symptom and had been told this. And your FSH level, you could do it every day for a month. And this is the one that is often used to, I'm going to be cynical, and to send women away from their GP. So over the age of 45, the NICE guidelines quite clearly say you don't need this wretched blood test to diagnose. It's really not particularly helpful from 40 to 45, because you could do it every day for a month and it could be normal for 28 days and it might spike on 2 days. And you have these women who are sitting in front of you, utterly broken.
Dripping.
Just saying, I can't work, I can't move, I can't, oh, but your blood test doesn't say this. And it's sort of, I think this is another thing with the speed of GP, 7 minutes, 10 minutes, you stop you lose the ability to see the person in front of you. And I think this is where you have to say, look, here is a symptom checker. This is a confirmed menopausal scoring system. And another thing I think you can say is, could I just try this for 3 months? Because GPs are terrified about HRT for the same reasons. Because they haven't been taught, so they're still going on this old, so they are often terrified. And I think for you to go in and be really informed and have read everything and say, could I just try it for 3 months and see what happens? And that takes that fear away from them. And then you've got that, you can leave things with them. I mean, I take my GP a book or something every day. He's got Jane Lewis's Vagina book, which raises, but I said, you have 50 hours of CPD to fill per year. Here's a couple of hours for you.
Yeah.
So it just is. I think the education isn't there. And it's that thing of, here's my gift to you. And here's another gift. And I'll be back next week with another gift. I'll get you to learn one day.
All right, well, thank you so much, Diane and Zoe, for joining me, and Sam, thank you for having us all.
Okay. Oh, it's my pleasure. Thank you so much for that, Katie, Diane and Zoe. I mean,
trying to talk quickly to get it all out.
Oh, I know. And as you say, you could go on days and days and days and probably still not cover it all, but such a wealth of knowledge on this massively important subject. So I hugely appreciate your time, as I'm sure does everyone else who is listening. So many comments, people commenting about so many things that they didn't know. So I know this has been really beneficial. So that's the end of Life Begins at 40. I do hope you all enjoyed it. I'd like to thank our sponsor, Lumity Supplements. As mentioned at the start, they've put an amazing offer in your digital goodie bag, so please do have a look. You'll receive an email on Monday with your digital goodie bag with offers and all of the resources from all of the speakers today, and also a very short survey. It really will only take a few minutes, and your feedback is very important to us, so we know what other events to do that you may like and what we can improve on. So that's it from me. Have a lovely evening and enjoy the rest of your weekend. Thank you, everybody.
Thanks, bye.
Bye.
Bye-bye.